pain has really transformed our understanding of what is going on. So as I've already said, it's like a textbook of rheumatic diseases. The resemblance to rheumatoid arthritis in some people, the resemblance to ankylosing spondylitis, except it isn't in some, to reactive arthritis, to inflammatory bowel disease, or you can get combinations of these. They're not mutually exclusive. And that's what makes diagnosis difficult, and it's what makes monitoring these patients difficult, especially when they're put in clinical trials. Unless you can find a very precise definition and include only patients who have a polyarthritis that looks like rheumatoid arthritis. But we know that's not the most common form of psoriatic arthritis. And that's why there's an evolving definition of the disease. What do we know about the etiology? Well, the important genetic influences. Guttate psoriasis can be precipitated by streptococcal throat infections. There's some evidence that psoriasis itself is associated with gut wall permeability, and there's one hypothesis that this is an explanation for the development of some patterns of arthritis. So again, the link with a reactive arthritis may operate through this sort of mechanism. There are other fascinating things about the immunopathology of both psoriasis and the synovium, because they do share many features with involvement of CD4 T cells, CD8 T cells, and the pivotal presence of TNF-alpha, both in the synovium and in the skin of patients with psoriasis. There may be clues here too. We know that a small percentage of people given infliximab will develop psoriasis. And in that population, there may be a tiny number who might get psoriatic arthritis. But psoriasis is seen in a tiny number of people with infliximab. Patients who are immunocompromised by HIV may get psoriasis and psoriatic arthritis. And the lower the CD4 count, the worse is that arthritis. It's not that common, but it's well documented. These should provide us with important clues about not only the mechanism for the arthritis in psoriasis, but psoriasis itself, and perhaps the mechanisms of many of the other rheumatic diseases that this condition can resemble. So this, again, is somewhat hypothetical. I mentioned the importance of genes. Many genes are now associated with the presence of psoriasis itself. And even within the last few weeks, further genetic associations have been discovered on the MHC. So the idea is that there's T cell migration from the dermis to the epidermis, from the subsynovium to the synovium. And they link with dendritic cells, which appear to be pivotal, as with nearly all other T cell, B cell mediated immune events. But again, TNF-alpha seems to be absolutely essential to the evolution of both the skin and the arthritis. There are differences in the synovial pattern between rheumatoid disease and psoriatic arthritis. And I've been emphasizing the differences all along between psoriatic arthritis and some of the conditions it resembles. So this is out of my own synovial pathology collection. This is a patient with rheumatoid arthritis, and here's that focus of lymphocytes that resembles a lymph node that you sometimes see in the subsynovium. And this is a patient with psoriatic arthritis. And note the relative paucity of infiltration